Bismillah ar-Rahman ar-Rahim. Today with a new presentation on acute severe asthma in intensive care. So firstly, and very quickly about the definition and the pathogenesis. Asthma is, as you know, it's a reversible airway obstruction which is characterized by a triad of bronchial smooth muscle contraction, airway inflammation and edema with increased secretions. And this is the difference between the normal airway and asthmatic airway. So as you notice, the result of that would be difficult inspiration and more difficult expiration. That's why there will be air trapping inside the alveoli. And this is the base behind the mechanical ventilation strategy we will discuss later. So just remember that the expiration is extremely difficult due to the obstruction, and there will be air trapping or intrinsic beep or auto beep inside the alveoli. This is the most important fact in the pathogenesis. The first thing you have to do is to classify your patient or stratify your patient into whether he is acute severe asthma or life-threatening asthma or near-fatal asthma according to the triage parameters: heart rate, respiratory rate, blood pressure, ability to speech, peak expiratory flow, ABG, and the CNS. The first patient, as you see, the acute severe asthma one is tachycardic, tachypneic, blood pressure is holding, so he can speak but with difficulty, and his BEF or peak expiratory flow is between 33 to 50% of predicted for his body weight and age. ABG still holding, meaning that the saturation is still above 90 on oxygen and still can wash the CO2 and is still conscious. So to summarize, the patient simply is still holding. The second patient is collapsing, started to be bradycardic, bradypneic, hypotensive, exhausted, and his PEF is below 33% of predicted for him, started to be hypoxic, start to fail to exhale the CO2, that's why it starts to be normal, and start to be confused and lose his consciousness. So this is life-threatening asthma. If the CO2 is high, this is the near-fatal asthma. So why this is important? Because it will affect your decision how to proceed with the patient. If the patient is acute severe asthma, you have time to try with SNPs, with steroids, with magnesium and such stuff. But if the patient is life-threatening asthma or near-fatal asthma, you don't have time. This message for both of them: don't waste time. Just intubate and ventilate your patient. Don't waste time. The investigations need to be done: full bloods, ABG, and chest X-ray. Very important to do chest X-ray for all patients with acute severe asthma to rule out a differential diagnosis like pneumothorax. Look at that pleural line and collapsed left lung, or a result of acute severe asthma. Pneumothorax could be a result of acute severe asthma due to the air trapping. Then now let's assume that the patient is acute severe asthma, is not life-threatening asthma. So how can we manage this patient? As usual, optimize ABCD first, then specific treatment. ABCD, airway breathing, just all you need is to put the patient on high flow oxygen and keep his saturation between 94 and 98%. For C, just secure good IV access and start hydration, because this patient is commonly dehydrated. For D, sedatives and the neuromuscular blockers, don't ever sedate the patient because he has high chance to recover without ventilation. So don't sedate acute severe asthma patient for any reason, because this is going to affect his respiratory drive as well. Then we'll start the specific treatment: SAPA and the SAMA-NEPs. Short-acting beta agonist NEPs, salbutamol nebulizations, 5 milligram, which should be repeated every 20 minutes for 3 consecutive doses, so total would be 15 milligram per hour. Very famous side effects for this SABA NEPs is tremors, tachycardia, hypokalemia. So take care of hypokalemia correction during SABA NEPs treatment. For SABA NEPs, short-acting muscarinic antagonist NEPs, which is ipratropium bromide, 500 microgram every 4 hours, and when it's combined with SAPA NEPs, it gives you much better bronchodilation than if you use SABA NEPs alone. And especially the side effects is minimal. So consider ipratropium bromide nebulization every 4 hours. Very important. Then the third medication is steroids. Very important medication in the management of acute severe asthma or life-threatening asthma. And it does improve the mortality as well. You can use either oral form, prednisolone 40 to 50 milligrams daily, or IV form, hydrocort 200 milligram stat, followed by 100 milligram every 6 hours. There is no preferred or way. You can use even the IV or either the IV or the oral route, and no way is superior to the other. So if you can give it orally, do it. If there is any other reason like vomiting, like peptic ulcer history, just go for the IV. Inhaled steroids don't have any role in the acute situations. So either oral, if I can't, just give the IV. IV magnesium sulfate. IV magnesium sulfate is smooth muscle relaxant. It produces bronchodilation, but can be given at a single dose, which is 1.2 to 2 grams. But please do it over 20 minutes to avoid hypotension. Very important. If the patient is life-threatening asthma or near fatal asthma, the message was don't waste time, intubate, ventilate. So the first step for the airway to intubate the patient. And I think this is the most important slide today. And this is the most important moment in the management of life-threatening asthma patient. Either you do it safely or we will kill the patient. There is very high risk of hypotension during the intubation trial, followed by respiratory or cardiac arrest after induction of anesthesia during the intubation. And this hypotension risk is multifactorial, probably because the patient is hypovolemic already, and after giving the anesthesia medication, induction, there is loss of sympathetic tone. Another reason that the patient has air trapping and very high airway or intrathoracic pressure, so the venous return is decreasing and the cardiac output is decreasing. For all these reasons, hypotension is very common during intubating the asthmatic patient. So remember and anticipate complications. Good preparation is always the key. Be ready for all scenarios. What should you do? Firstly, pay extra attention to pre-oxygenation before doing rapid sequence induction intubation. Pre-oxygenate the patient as much as you can. Secondly, start IV fluids before anesthesia induction. And be ready with the vasopressors in your pocket, metronidazole, or start the noradrenaline in case there is hypotension. So I mean, we need to take the move first. Don't surprise with the complication and run after the patient. You have to take the move first, anticipate things, and prepare yourself to deal with the complication. So this is very important. Anticipate hypotension during intubation. Give fluids, pay extra attention for pre-oxygenation, and prepare vasopressors for possible and expected hypotension. If we did the intubation successfully, we would move to the next step, how to sedate the patient. Now we'll discuss D first, then we'll be back to B, the details of mechanical ventilation. For D, the sedation, we have many options. Now the tube is in, we connect the patient to the ventilator. We need to sedate the patient. Propofol alpha is very common combination, but we can't use it for long time because of propofol related infusion syndrome. So usually we switch to morphine midazolam, but take care that morphine could have the risk of histamine release sometimes. That's why some consultants don't prefer using morphine in acute severe asthma patients. And if the patient situation is really hard, we can consider ketamine as sedative agent because ketamine has very nice bronchodilator effect. So we can put the patient on propofol alpha with ketamine, morphine midaz with ketamine, as you like. For neuromuscular blockers and paralysis, we have pancuronium, ricuronium, cisatrac. All are ideal options, but the message I want to deliver today, avoid atracarium by name because of the risk of histamine release and anaphylaxis. Don't use atracarium in life-threatening asthma. And NMPs should be stopped as soon as possible. Then we'll start to stand in front of the ventilator and put our strategy. Here we have two missions: to correct hypoxemia and to help the patient to get rid of the air trapped inside. Dealing with O2B is the target of this strategy. That's why this is an example for what we can do by the mechanical ventilator, like start with SIMV mode with tidal volume of 6 ml per kg, ideal body weight, very low tidal volume because I don't want to add more to his air trapping. And very logic that I have to prolong the expiratory phase to help the patient's lung to get rid of the air trapped inside. So the easiest way to detect whether there is O2B or not is the flow time curve on the ventilator. This is the inspiratory part, and this is the expiratory part. So as you notice, the expiratory part didn't reach to the baseline before starting the next breath. This is the air trapped inside. So this dotted one is the normal one. Should reach to the baseline before starting the next breath, but it didn't happen here. So this patient has some air trapped inside his lungs. That's why we need to prolong the expiration and give the patient's lung a good chance to get rid of all air trapped inside. We do it by slowing down the respiratory rate. Slowing down the respiratory rate, so give more room for the expiration. And IE ratio, inspiration-expiration ratio, should be 1 to 4 at least. So prolong the expiration again. For the beep, in deeply sedated patient, paralyzed patient, life-threatening asthma, beep should be 0. Any added beep would be added to his intrinsic beep inside. So this is not the situation to put a beep at all. And the both time, which is the time between the inspiration and expiration, the time of plateau pressure, this time should be 0 also. All those things because we need to prolong expiration as much as we can, helping the lung to get rid of all the air trapped inside, improving the O2 beep. So small tidal volume and the small respiratory rate. Okay, so it's expecting that because of that strategy, the CO2 wash wouldn't be enough. But this is fine, and it's called permissive hypercapnia. It's fine as long as pH still above 7.2. What are the targets of this strategy? To correct hypoxemia, to improve the intrinsic beep to below 10 centimeter water, keep plateau pressure always below 30 centimeter water, and pH it's expected to be quite low, but At least we need it above 7.2. 4 targets. Okay, that means I need to measure intrinsic beep and the plateau pressure every 4 hours to make sure everything's fine. How can I measure the O2 beep? The patient should be deeply sedated and paralyzed before trying this. On your mechanical ventilator screen, you will find 2 buttons, expiratory hold and inspiratory hold. To measure O2 beep, you need to press on expiratory hold, like this. So no inspirations. Then the machine will detect this pressure level. This is the O2 beep, which is measured here like beep of 17. So my SID beep is 0, like we mentioned. So this 17 of beep is the intrinsic beep inside the patient's chest. Let's imagine that there is SID beep of 5 here. You have to discount this from the total beep measured here. So if the total beep of 17 and there is SID beep of 5, this means the intrinsic part inside the patient is 12. But here it is 0, SID beep is 0, and measurement is beep of 17. That means that the patient has intrinsic beep of 17, which is still above 10. So I need to keep going with our strategy to improve the intrinsic beep. If it's quite high, above 10, what can I do to improve it? We mentioned that decreasing the respiratory rate. So this gives a good chance for the expiratory time to be longer. Decrease the volume. I don't need high tidal volumes here. It's just 6 ml is fine. If you tolerate 5 ml or even 4 ml per kg, it's fine. Increase the inspiratory flow rate. This means faster inspiration, shorter inspiration, so longer expiration. Very simple. And bronchodilator therapy, as discussed before. So all the strategy depends on just to prolong the expiratory time to improve the intrinsic beep. That's it. For the plateau pressure, this is the measure which tells you that the alveoli can't be distended with more air. So I can't give more air inside if the plateau pressure is higher than 30. Very nice. Can be managed by or measured by pressing and holding the inspiratory hold button like this. And again, the patient should be deeply sedated and paralyzed. While doing this, no expiration. It's holded, measuring the plateau pressure, which is recorded here like P-plat, like 31. So it's fine, accepted. We needed 30 or below. So expiratory hold to measure the O2 beep, or inspiratory hold to measure the plateau pressure. We need to do this every 4 hours and make sure about your targets.